Hello. Today we're going to discuss mental health 4 or the depression portion of bipolar disorder. First of all, I'd like you to think about this question. The priority nursing diagnosis for a hyperactive manic client during the acute phase is ineffective role performance, risk for energy, risk for other directed violence, or impaired verbal communication. The correct answer for this question is risk for injury. Okay, so there's different types of bipolar disorders. We have bipolar 1, bipolar 2, cyclothymia, and hypomania. Bipolar 1 disorder. This is when a patient has had at least one episode of mania alternating with major depression. With bipolar 2 disorder, the client has had hypomanic episodes alternating with major depression. Cyclothymia is characterized by hypomanic episodes alternating with minor depressive episodes at least 2 years in duration. And hypomania is a mild mania characterized by optimism, excitability. The person's very energetic. They have productive behavior, a marked hyperactivity and talkativeness, heightened sexual interest. They are quick to anger and they are quickly irritated. They have a decreased need for sleep. And these patients generally need to be observed before they have a full-blown manic episode. Now, again, I'm not going to test you on percentages of the population, but I think it's important to note that 1.2 to 3% of the U.S. population has bipolar disorder. Okay? Substance abuse is going to be a common thing that you will see with patients who are suffering from bipolar disorder, either to help them come down or help them get that feeling of the manic episodes if they're not in a manic state at that time. There are also other disorders that are associated with bipolar disorder, and that would be the personality disorders and anxiety disorders. Now, there are sociological findings that a person's education, occupation, economic status, and creativity are all areas that you would see differences for this person that's suffering from bipolar disorder. They may be, very, very creative when they're up in their manic state, but then they kind of lose that activity or lose the drive to be creative when they are depressed. Their economic status, a lot of times when patients are in their manic phase, they will just spend. And so they oftentimes are not in a good economic status. With their occupation, the person may do really well when they're hypomanic or in their manic states, but when they get depressed, they will have problems at work. Okay, there are also some psychological influences regarding to bipolar disorder. These patients generally will highly express any emotions that they have. And when they grew up, they may have grown up in a household that had someone who was just very expressive, and that may have helped guide them into developing bipolar disorder. And again, childhood experiences can play a large part in diseases or problems that people develop later in life. Okay, so when we want to do our assessment of this type of patient, it's very important to note their mood. They may be hypomanic with just the mild symptoms of mania to full-blown manic. They can have feelings of being very social and euphoric, which can turn to hostility, irritability, or paranoia. Generally, their behavior, they are very hyperactive. Usually in the manic stage, you're going to see bizarre or colorful dress. They will also be highly distractible. It'll be like, just little things will take them to where they are bouncing from object to object or topic to topic. And in the manic state, this patient is going to be very impulsive, and that's where you see a lot of the spending that comes along with the manic state. This patient's thought processes, they are going to have flights of ideas. Ideas are just going to be flowing in and out, and they may jump from one to another before you realize that they've left the first topic. They're going to have thoughts of grandiosity. They are just wonderful, they're great, they've got money, they can spend money on what they want. And they're going to have very, very poor judgment. Now, with their cognitive function, they will have significant and persistent cognitive problems, and they will have lots of difficulties in psychosocial areas. Now, we've talked before about self-assessment of the nurse. It's very important that we continue to assess what our feelings are and maybe what we may be taking from the patient. With a manic patient, you need to watch out for those behaviors that may start just bothering you. The patient number one is going to be very manipulative, and so you need to avoid that. They can also be very aggressively demanding in what they want. They know what they want it right now, and you better get it. The other issue with a manic patient is a lot of times they will do the splitting behaviors like we've talked about before, where the client is going to try to pit one group or staff member against another. One nurse is going to be super nurse and the other one's just going to be pitiful. That's where frequent communication among the staff will help you avoid that causing problems within the staff. Now, as far as staff member actions, you need to set limits consistently and follow those limits. And then again, you will have the frequent staff meetings to deal with the patient's behavior and the staff response, because these patients, when they're in the manic stage, can just really wear you down. Another part of our assessment is going to be to assess the patient to see if they are a danger to themselves or others. You need to assess, are they having suicidal thoughts or plans? And it's very important to document that information. And, as far as the plan, how easy would it be for this person to follow through with that plan? You need to know that. When a patient is in the manic state, they can exhaust themselves to the point they die. Okay? They, a lot of times, will not eat or sleep for days at a time. Okay, so if you see that this person's up for days and days and days, they're not eating, they're not sleeping, we need to look at, okay, right now the most important thing are the physiological aspects to this patient. We have got to get them to eat and we have got to get them to sleep, because their bodies will physically shut down and they will die. And remember that patients in the manic state will have poor impulse control. So, they may strike out at you or at others. Some of the nursing diagnoses that you may see with the manic portion of bipolar disorder: risk for violence. Again, with that poor impulse control, they may lash out at any time. They may have defensive coping. They may have ineffective coping, disturbed thought processes, and situational low self-esteem. So as far as our outcomes, in phase 1, that is the acute phase or acute mania state of the patient. The very main concern that we are going to have is to prevent energy. We need to make sure these patients are hydrated, that their cardiac status remains stable, that they maintain tissue integrity, that they sleep and rest. We need to work on thought self-control, and above all, we don't want the patient to attempt self-harm. So, preventing injury is our goal for phase 1. Now, phase 2, that's the continuation of treatment. Here is where we want to pull in things that can help the person avoid a relapse, such as educational classes, support groups, communication, and problem-solving skills. And then here we also want to work on medication compliance. That is more possible to work on these type of items once you have reached the phase 2 and the patient is not in that acute manic stage. Then phase 3 outcomes. That's where we have the maintenance treatment. We want to, for the patient then to be able to participate in strategies and therapy and, determining triggers possibly for their actions. Now, as far as our planning for these different stages, In the acute phase, we have to make plans for maintaining that patient's safety, for medication stabilization, so you may be changing the medicines around a bit, and for self-care of that patient. For the continuation phase, this is where we want to maintain medication compliance, perform teaching for the patient as far as different coping strategies, different triggers so that they learn more about what's going on, and individual counseling as well. And planning for the maintenance phase, that's just where we want to prevent a relapse. Now, our interventions in the acute phase. This is where we will use communication with the patients and the staff to develop a plan for the patient. We want to provide a safe milieu for that patient, a safe environment for them to where we can help avoid them hurting themselves. We have to look out for their physiological safety and their self-care needs. We have to see that they are eating, they are sleeping, they are drinking, they're taking a bath, they're taking a shower, caring for themselves. Now, when you communicate with a manic patient, it is very important that you use a firm, calm approach. If you start getting flustered and agitated, your patient is going to also become flustered and agitated. So, very important that you use that very firm and calm approach. You want to give short and concise explanations. Long paragraph explanations are not going to be easy for this person to follow. So just short, concise. You want to remain neutral. Do not get into a power struggle with this patient because they're going to feel like they have to be on top. Okay? Be very consistent in how you approach them. Be consistent in the expectations you have for them. And be consistent in what will happen if the expectations are not met. And also, you would want to try to firmly redirect the patient's energy into some other activity. Now, one of the medicines that you will see bipolar patients on is lithium carbonate. It is a mood line stabilizer. It's a first-line agent of treatment. But generally, this drug is going to take 7 to 14 days to reach therapeutic levels in the blood. Okay? Sometimes, well, not sometimes, what you have to plan for is what are we going to do between those 7 and 14 days when the lithium takes effect. So, until that time, they may be on lithium plus the antipsychotics, okay? With antipsychotics, some of the side effects you may see would be slow speech. It'll help inhibit any aggression, but it will also decrease their psychomotor activity. They also may be on antipsychotics or benzodiazepines to prevent exhaustion. Remember, we got to let them sleep, and sometimes they're going to need something to help them relax, help them slow down. It's also to help prevent coronary collapse and death. And these are very real possibilities for a manic patient if we don't intervene with medications and treatment. Okay. With lithium, I want you to know the expected side effects, okay? Some of the signs you may see are the fine hand tremor, polyuria, or large amounts of urine. They may have a mild thirst or nausea. Sometimes they're just generally uncomfortable, and they can start to gain weight on this medication. Okay. And then I also want you to know signs of toxicity. Early signs of toxicity are nausea and vomiting and diarrhea, thirst and polyuria, slurred speech, and muscle weakness. Okay. Let me back up for a minute. Advanced signs of toxicity are a coarse hand tremor, persistent GI upset, they are mentally confused, and they will have hyper-irritable muscles, and they will be very uncoordinated in any type of movement they make. And then the severe toxicity signs would be ataxia, blurred vision, clonic movements, large amount of dilute urine, seizures, stupor, severe hypotension, coma, and then death. So our goal here would be to intervene at the very earliest sign that the patient is becoming toxic to the lithium. So you're going to have to watch that closely. Okay. There are major long-term risks with lithium. The patient, if they stay on lithium for long term, they may develop a hypothyroidism and have to be medicated or treated for that. And it also can affect the kidney's ability to concentrate urine. And so you would want to watch their thyroid levels and their urinary function, their BUN and creatinine, to ensure that they are not having issues. Now, there are contraindications to lithium, and these are very important to know, because if your physician comes up and orders that for someone with these symptoms, that's when you'll want to step up and say, I just wanted to check, this patient has cardiovascular disease. Are you sure lithium is what we want to use? And then discuss with the healthcare provider why he may be wanting to try lithium. But if the patient has had brain disease, renal disease, or thyroid disease, they really shouldn't go on lithium. Again, also, if they have myasthenia gravis or pregnancy, they should not go on lithium. Breastfeeding mothers and children younger than 12 should not go on lithium. Okay, it's going to be very important that we teach the client and the family about lithium. Okay, we want them to know what are the expected effects of the treatment. What are the signs that you might see, like the fine hand tremor? Okay, they need to know how important that it is to consistently monitor the lithium blood level so that they do not become toxic. They need to know what can happen to the patient if they do become toxic. So we want to let them know the known side effects and what toxic things they might see if the patient is becoming toxic. We also need to discuss with them what foods or over-the-counter medications can affect the lithium therapy. And then they definitely need to know when do they need to stop and call the physician. Okay, if the patient does not respond to lithium or they don't tolerate it for some reason, maybe they have one of the contraindicated diseases and they can't take it. Some of the drugs that they may use would be Tegretol, Depakote, Lamictal, Neurontin, or Topamax. In addition, you may see anxiolytics used like Klonopin or Ativan, or some other antipsychotics that you may see used would be Zyprexa and Seroquel. Now, you've already gone over electroconvulsive therapy, and so you know a little more about it. Electroconvulsive therapy can be very effective if a patient is having severe manic behaviors, or if they have rapid cycling, like they're going through depression and popping back to the manic stage, and it's just constant. There's no time limit that they're settled in either the manic or the depressive phase. If the patient's having paranoid and destructive features, ECT can help reduce some of those symptoms. And if they're acutely suicidal, they may try ECT to see if that can help.